but before I introduce ourselves, can I just ask whether you've got any conflicts of interest, because we haven't actually had anything from you yet to say what your conflicts of interest might be. Now, you may want to think about that and to send us by email or whatever what your conflicts of interest are. That be all right?
I can tell you now, I don't regard this as a conflict of interest, but I was one of the participants in the Ward and Hilton trial of TVT, which took place from 1997, and the final report was the 5-year outcome data to which I contributed.
Right. But thinking of the sort of pharmaceutical industry or anything like that, are you sponsored by
I mean, in relation to the MESH review, I don't believe that any of the pharmaceutical industry relations would have any bearing. It's all been to do clinical research or to give lectures, and it has no bearing on my involvement with meshes or tapes.
Right. So you're sponsored for research?
Yeah.
Well, that would be helpful for us to know that.
I can let you know that.
Right, thank you. Annie?
Thank you. So I'm Natalia Price, consultant urologist.
I'm so sorry, I'm a bit deaf. Could you speak up?
Sorry, Baroness. I'm Natalia Price, I'm consultant urogynecologist in Oxford. I don't think I have any conflict of interest. I can definitely nothing to declare. If I something think about it, I'll definitely email you, but no conflict of interest from me.
Thank you, that'd be really helpful.
Simon Jackson, urogynecologist in Oxford. I don't think really there's any conflict. I mean, Oxford was in receipt of an educational grant for about 10 years from Ethicon. It came with no strings attached, but it was to run an anatomy course where we taught anatomy for various operations, including some mesh operations. So don't really work with industry in any other way. I've done private surgery over the years, so been paid to put mesh in and take mesh out, but no other conflict.
Right. Okay, thank you very much. And if you have further thoughts, just do let us know. As I said, we've been going around the country listening to a lot of women, and we've been to Wales, to Northern Ireland, to Glasgow last week, and hearing the stories that they have got to tell us, because that was part of the remit that we were given when Jeremy Hunt asked us to do this review. Having done those visits, we are now obviously into our oral hearings, and we're hearing from all sorts of people, taking evidence from a great number of people, and started with patient groups and we will finish with patient groups. So we're listening, learning a lot, and have listened a very great deal. So if I could start by just introducing the team to you, and then if you would be kind enough to introduce yourselves and say where you're from, and that will be on our screen. So we are videoing this, and I hope that's all right, and it'll go on to our website so people know what is going on, because one of the things that's come across very strongly to us is that people have been very anxious about secrecy and all the rest of it. So we're being as open and honest as we possibly can. So I'm Julia Cumberledge, and I've been asked to chair this review by the former Secretary of State, Jeremy Hunt, and we have our terms of reference onto our website, so you can see what we're doing and why we're doing it. On my left is Sir Cyril Chancellor, who's the Vice Chairman of the 3-person panel that we've got, who are taking the decisions concerning the review and all the aspects of it. And then on my right is Simon Whale, who's the third member of our panel, and Simon particularly deals with communications and lots of other things as well. And then on Simon's right is Dr. Valerie Brass, and she's our secretary to the review team. And on Cyril's left is Sonia MacLeod, Dr. MacLeod, who is our main researcher. And then in the room we've got other members of the team who are here just to help us run this session. So perhaps you would like to start by saying who you are and perhaps your special interests, so that would be useful.
Yes, thank you for asking us. I'm Linda Cardozo and I'm Professor of Urogynecology at King's College Hospital on the other side of South East London. I was appointed a consultant obstetrician and gynecologist there in 1985, and I've been Professor of Urogynecology since 1994. I've got a major interest in women's pelvic floor disorders, and I run a 13-person multidisciplinary team at King's, providing all forms of treatment for women with prolapse and urinary incontinence, including conservative therapies, pharmacological therapies, and surgery.
Thank you very much. Yes.
Thank you. I'm Natalia Price. I'm a consultant urogynecologist in Oxford University Hospitals. So I was appointed as a consultant 2010. Sorry, and yes, I'm a urogynecologist. I do have passion and interest helping women with pelvic floor disorders and offering range of treatments. And over the last 9-10 years as a consultant, I've also been helping women with MASH problems and working as part of Oxford multidisciplinary team of clinicians, helping women with MASH complications, but overall with pelvic floor disorders.
Thank you very much. Yes.
I'm Simon Jackson. I work in Oxford too as a urogynecologist. I've been there since 20 years. So I work with Natalia.
Right, thank you very much indeed. So perhaps I could ask all of you, I mean, as I say, we've been around the country, we've heard a huge amount from women who've had mesh implanted. And one of the things that has come across to us is that they are very concerned that they can't get access to the services that they feel they need. For example, translabial ultrasounds. That's something that they feel is very important to them, and that it can identify where the mesh is. And so they really feel that without access to this service, that they really are not cited about what has happened and where the mesh is at the moment. So I wonder if you've got any thoughts about the services that women can't access, and particularly translabial ultrasounds.
Well, translabial ultrasound hasn't been proven to show any significant mesh disorders, and usually they're diagnosed clinically. We are able to provide translabial ultrasound, but it doesn't necessarily give an answer to a woman's problems. If she has pain, it's not going to tell you why she's got pain. It may show where the tape is if it's a synthetic tape for incontinence, but at the moment there is not a significant body of research evidence to show that it's beneficial in the management of these women.
So, well, perhaps I hear from all of you and then...
Yeah, sure. So translabial or pelvic ultrasound, which can be translabial or using endovaginal probe, can be internal scan, is not really validated imaging modality to specifically to treat or assess women with MASH complication. It has its role, but it's not validated. So it can be used as part of the investigations, and it does have its role. Out of all other imaging modality, transvaginal scan or pelvic scan or translabial scan helps to locate vaginal portion of the mesh. It's not helpful for abdominal portions of the mesh or growing portions of the mesh. Transvaginal or translabial scan simply doesn't detect those. However, it's not validated modality. It hasn't been, and interpretation of the scan has to be taken very, very carefully. Any tissue, scar tissue that doesn't belong to vagina, so which can be formed as a result of previous surgery, not necessarily mesh surgery, can appear as scar tissue, as artifact. So interpretation of the scan have to be, taken into account. Clinical history have to be interpreted by a clinician, urogynecologist, knowing women's history, knowing the problem. So it has its role definitely as part of the investigation. It does, however, it's not the only investigation, and we really need to look holistically at those patients. So simple internal examination will give you often more information about position of the tape, tenderness. Simple vaginal mesh erosion will be detected on clinical examination, and translabial scan doesn't really add much to it. Nevertheless, yes, this scan would have sometimes even reassuring points. Some women come in upset about the tape migrating, and performing scan showing them that tape is in a single place, in the right place, in single piece, gives them reassurance. So yeah, it does have its place role, and that's what NICE guidelines reflects. But it's not, I wouldn't focus purely on this. It's about a holistic approach to these patients.
Thank you.
Well, when someone's presenting with a mesh complication, you want to know whether the mesh is in the wrong place, and that is, as we've heard, a combination of vaginal examination will tell you whether the mesh is in the vagina. You want to know whether the mesh is in the lower urinary tract, and the best test for that is a cystoscopy. If you think the mesh may have migrated into bowel, you'd be looking at a sigmoidoscopy, and then that might be backed up with imaging, and the MRI would be the imaging that tends to give the most information. So a translabial scan is really just looking at the bit between the labia, and it's the bit below the vagina and the urethra. So it's not something that we routinely offer because we don't find it has clinical utility, but I am aware that many patients have been requesting it.
Does it offer anything about the tension of the
No.
Nothing at all. I mean, there is a communication problem here, isn't there?
Yeah.
Because of course it has become a very important feature for so
Yeah.
many women. And if it's not being offered by the NHS, they are going privately
Yeah.
for this, and they're being exploited to
Yeah.
some extent. The price of
Agree.
these things are rising. So how are we going to deal with this problem? They're under a very clear impression they need this. They feel they're being forced into the private sector because the NHS doesn't offer it routinely, and they're paying.
And some of them are very vulnerable women.
Yes.
I think this sort of information-seeking exercise may be useful in that regard.
A lot of it is about expectations, isn't it? The problem is that if women are told that this is an investigation that can see if there's something wrong with a synthetic tape, then obviously they will cling to that, thinking that if they have this investigation, it may help with their management. The problem is that if you look at the evidence base for the use of translabial ultrasound, it just isn't there. And I mean, this is something that I looked up recently to see if there was a body of evidence, and there isn't. So it's unfortunate and it's inappropriate advice to women. And I don't really know where they're getting it from, but there must be people who are out there who are profiteering as a result of it. And obviously that's most unfortunate.
I mean, we have had patients who've come to us having had translabial scans that have shown mesh, and we know they haven't got mesh because we've taken all the mesh out, but they've had other operations that have given them scar tissue, and that's been misinterpreted. So,
Or even childbirth injury.
If you're using a test clinically, you do have to validate that test in some way.
I completely agree, and it's very worrying because those are very vulnerable patients. They've already been through suffering, they suffered physically and psychologically, and it's very important because I came across cases that I do feel that those vulnerable women have been misled and advised to seek private translabial scan, and actually the findings of the scans been very poor, and interpretation of them, and those patients been left it just added to the suffering of those patients. So I think tighter regulations would be very welcomed, and because at the moment it's not well regulated, and we do need to acknowledge limitations of translabial scan and indeed stop this practice.
Mr. Jackson, you were mentioning about taking out the mesh, and perhaps I could pass on to Sir Cyril on that one.
You'll be aware that one of the conditions around the pause was the organisation of between 4 and 7 centres across England, which will be attested as having all the resources, including the clinical expertise, to undertake mesh removal, and that process of identifying what those resources are and testing to the centres is underway at the present time. We've got an operation which sometimes goes wrong, and which is not actually always possible to remove, so we hear, the mesh that's been put in. So we've got people doing an operation who won't actually be skilled to undo it and put it right if it goes wrong. So if we're going to have 4 to 7 centres across England where they will be skilled at taking it out, should they provide a hub so they're part of the country to actually work with the people putting it in, so that we are sure that those people who are doing the operation to put it in, where that is indicated, are actually themselves competent. I mean, I can tell you from my own experience of looking after children with end-stage renal failure, we established a number of centres to make sure that we had the expertise there to do the job. And so it's the same sort of philosophy.
And clearly the people putting the meshes in also need to have the appropriate expertise. It comes down to numbers at the end of the day. I mean, the vast majority of people who've had meshes put in have not had complications, so that's why the numbers being taken out will be much smaller than the numbers being put in. So you will need more centres putting mesh in than taking mesh out.
Mm-hmm. Are you talking about tapes for incontinence or meshes for prolapse?
No, I'm talking about stress urinary incontinence.
Because I think they are two different
They're completely
animals.
different, I accept.
Yeah. And I agree with Simon, because of the number of women who suffer from stress incontinence and who come and request tapes, because relative to other procedures we carry out, the complication rate is relatively small. Numerically it's high because so many women have had tapes in the last 20 years. But I don't think that you need to be a mesh removal centre in order to put in a TVT, but you do of course have to know where to access care should that be required in the future. But it would be like saying you can't do any form of surgery unless you can undo it, and often surgery requires a much different approach to redoing it or revising it or undoing it than to initiate.
I think what I'm suggesting is that the people who are putting it in different parts of the country, it might be sensible for them to work with the centres who are skilled at taking it out. In other words, we could work as a sort of team.
I think logistically and geographically in some parts of the country that would be difficult. I mean, it's not difficult for me in London because everyone is close by.
But if you're going to have 7 centres, removal centres across England, then presumably you'll be able to cover the geography reasonably satisfactorily.
At the moment, with the British Society of Urogynecology, there are 18 centres that had registered as appropriate to provide all of the facilities for mesh removal. I, for instance, didn't put us down initially as a mesh removal centre, not that we haven't been removing meshes, but because I felt that the workload would be too heavy on the NHS and that I wouldn't have facilities to take on that amount of work. Obviously in Oxford they are a hub and they have their local community that they serve, so they're both putting it in and taking it out.
But the process that NHS England is going through at the moment in specialist commissioning will be designed to establish and commission 4 to 7 centres as expert removal centres. That process is going on. It's one of the conditions of the pause.
Well, I think that's very straightforward in London. So from my point of view, it's easy. We all know who is good at what and who provides which services.
Well, this isn't part of our review. This process is actually going on at the present time.
Oh yes, I know.
Okay.
I know.
Can I ask you then, if you are really saying to us that you've got to have many more places in order to insert the mesh, rather than just rely on these centres, which they also take the mesh out. As clinicians throughout the country, how are you ensuring that the expertise is there to insert the mesh correctly? Because we have heard a lot of cases where actually the patients themselves are pretty convinced that it didn't have the expertise that was necessary to insert the mesh. And if you are people who are not taking out the mesh, how do you know whether it's actually gone wrong or not?
So, can I take you back a little way? When I started out, people were doing anterior repairs for stress incontinence, and it wasn't a very good operation. And then with the introduction of the colpo suspension, which is what most urogynecologists were employing for stress incontinence surgically prior to the late 1990s, it was a much more difficult operation. And so generalists in gynecology weren't likely to have a go at doing it. Unfortunately, the tapes were seductively easy to introduce. And so women with very mild stress incontinence would say, me too, I want one of those because it's a quick, easy fix and I won't have to do my pelvic floor exercises and I won't have to take any medication. And therefore, many of the generalists who not only weren't trained to do these procedures, but who did not have the facilities to appropriately investigate the patients or to offer them other forms of treatment, started doing it. And I absolutely agree that this has brought a good procedure into disrepute, and it's a terrible shame that it's taken patients suffering to bring that to light. But I think that you can designate centres as urogynecology centres without them necessarily being mesh removal centres, because as we use significantly less mesh and women have choices to choose other procedures now, I think you can manage to have mesh centres that are designated for complications, but there are still a lot of women with stress incontinence who will seek a surgical solution, and the NHS in any one hospital is not going to provide those facilities. It just would not be possible.
But would it not be sensible for these specialist urogynecological centres who don't do mesh to have a relationship with a centre that does mesh removal so they get the feedback and the learning? Because one of the things we've met as we've gone around the country is women who are lost. Things have gone wrong and they don't know who to go to because there's no connection between the person who put it in and the people who are taking it out.
Well, I think we've become a lot more focused on multidisciplinary team working. I mean, I think everywhere has their MDTs now, and every surgical procedure certainly that we do on women's pelvic floors goes to the MDT before a decision is made. And I think most people know where to access a regional MDT if they don't have a good, thorough local one.
I mean, our real concern is, we have many, but one of our concerns is that we want to be absolutely certain that the people who are inserting the mesh have the expertise to do it so that it is an operation that is successful. And we've heard many stories where the consent was actually not explored and it was sold to women by their clinicians, surgeons, whoever, that this was the answer, and that actually they weren't given the alternatives. Now, can you assure us that that is not the case now?
I don't think it is the case now. I hope that it hasn't been a very widespread problem, because the majority of people that we meet at meetings do provide informed choice for women, and especially following Montgomery, we've all been training our juniors and our nurses to do exactly the same. And I think having a patient decision-making guide will help, and I think also being able to offer all of the range of procedures would be a very good thing. I've never stopped doing colpo suspensions because I was trained to do them, but a lot of my younger colleagues can't because they were only taught to use tapes. And therefore, if you can only offer one operation, it might not be the right choice for all women.
Can I follow that up? Because that goes to the heart of what is informed consent. If you can't offer the full choice, you actually haven't offered full consent, or you haven't entered that process. I'm not saying that the individual consultant that you see, because obviously you can pass them on to somewhere else. But when we heard from B-side, it was very clear that with the introduction of the pause, there was certainly time to take stock and reflect on the skills of those who were offering procedures for the treatment of stress incontinence. And it was made very clear to us that there needed to be retraining. And one looks at some of the figures that we've received from the individual mesh centres, the numbers of colpo suspensions being done in previous years have been very low, if not at all. So you have to ask yourself whether in those centres there was ever full informed consent, and actually the procedures were fully available to all women. And I'm not quite sure what your experiences are. I mean, clearly I hear from you as a Cardozo that you've always been doing it. I'm not sure whether that's necessarily the case everywhere else, and whether one's had to ramp up the skills base to be able to offer the alternatives.
Can I interject? I mean, colpo, it isn't just about mesh, this really, in the bigger picture. Colpo suspensions are complex operations, and the same arguments apply. If a colpo suspension is done badly, there will be significant complications, as with any operation, really. So it's important that the skills are there, whether it's mesh or whether it's non-mesh. And again, it comes down to numbers. And you're right. You should. I don't think you have to be able to offer everything in a particular centre, but you need to be aware what's available and offer to refer patients on if you're not offering that particular procedure yourself. To come back to should the mesh removal centres be liaising with the mesh insertion centres, I think yes. It's rather analogous to how cancer care was reconfigured years ago. And I think the new NICE guidelines, which I think are very sensible actually, we're going to have a rethink about how we run our MDTs. The regional MDT is a new development for many of us, which is going to require resourcing, and it's going to change the way we work. It's certainly going to change the way we work in Oxford, and I think probably across the UK. And I think a combination of the NICE recommendations and the pause for this review, it's going to have some very positive impact on our speciality actually, because it has allowed time for reflection, and I think it's going to mandate proper resourcing of follow-up of patients to see whether they get complications, and proper beefed up MDTs. There's going to be all sorts of positive spin-offs.
Yeah, so I agree with Mr. Jackson that this pause, high vigilance procedure, NICE guidelines, it's been very positive. It gave us time and actually power, because we have more resources locally to think, to reflect, but ultimately to give them more choice, to empower patient to make the decision, to give them all the choices available. So, which is really important, it's paramount. So, with NICE guidelines is very comprehensive document, clearly states that any surgery for pelvic floor prolapse or incontinence primary needs to be very careful, discuss and weigh pros and cons. Any surgery has complications. So this high vigilance procedure period and Baroness Cambridge review really has helped and makes us think. So it's very positive development.
I mean, it's kind of interesting that it's taken us to make you think.
I think the process started before, but generally, if you look in medicine, surgery, if you look how training was around 20, 30 years ago, even 10 years ago, we're all progressive, it's all getting better, and so it's not new, but actually it has helped us because it helped us, for example, locally, help us to strengthen our MDT, to have more nursing support or coordinators to streamline, because you can't run this on goodwill alone, and it has been, for like British Society of Urogynecology is charitable organization run by volunteers. Database was established as a volunteering sort of database. So it's the source process been there for a long time, but it helped us, give us more way.
Can I just ask another question about the pause? So how are you managing patients during the pause? So if a woman presents with SUI, you're not able to offer her mesh at the moment. What do you do for and with that woman?
Sorry, you carry on.
We do. I mean, we offer them the operations that we know work for stress incontinence. So we have some patients waiting at the moment for hoping that the retropubic TVT is reintroduced. We have patients who choose to go ahead with cold plate suspension. We have patients who go ahead with fascial slings, and we have a lot of patients at the moment who are having injectables, knowing that the injectables are not terribly effective but have a good safety profile, just waiting to see what's going to happen in the future.
It is very sad to have patients waiting, and I don't know how many people you've spoken to who have had successful tapes for stress incontinence, but as you can imagine, over the years, both in the NHS and in my private practice, I've had a number of significantly high-profile women who have had tapes, but they don't come forward and talk about it. First of all, they've moved on, they've been treated, they don't want to talk about incontinence. And secondly, now they're trolled on Twitter if they come forward and say something, and so they're frightened to do so. And we have a significant number of patients who were waiting for a tape and continue to wait, incontinent with pads, because they don't want a big operation like a colpo suspension, which they know has a complication rate. They don't want an injectable because they know that it might not work for long, and if it does, it will have to be repeated. And they think that if they wait, they will get a retropubic TVT, which is what they had signed up to, having read the leaflets and having been counselled about all of the alternatives. And a lot of that is about expectations, because if we didn't have the tapes, that wouldn't be their expectation. But at the moment, they still think that they will be able to have one if they wait. And that's quite sad for them.
Roughly how many sort of are we talking about?
We brought back all our patients who were on the waiting list for tapes and discussed with them the alternatives. And I can't tell you exactly how many it was, because we are 4 consultant urogynecologists, so they didn't all return to the same clinic. But I saw about a dozen who were on our waiting lists expecting to have their tapes within the foreseeable future. If their mother had had an operation for stress incontinence, they were happy to have a colpo suspension. And if they knew someone who'd have an injectable, they'd have that. But the rest of them are waiting still. And it's nearly a year now that we've suspended their treatment.
Are they still on the waiting list?
Well, no, they come back to clinic periodically to see if the tapes have returned. In fact, Thursday before last, I saw a woman who said, but you told me that the guidelines would be out in April. And I said, well, the guidelines are out, but the pause has not yet been reversed. So I still can't do anything for them.
They're not allowed to be on the waiting list because then they would breach the waiting list. So they're in a...
Yes, we've heard about that. It's a sort of catch-22, isn't it?
Well, it is difficult because the NHS funding is limited. And so you can't just keep people on a waiting list if you don't know when their turn is going to come, because the hospital is fined, as I'm sure you're well aware, if anyone's been waiting over 52 weeks, and it's coming up to that now.
Can I just ask you, just thinking about the history and how tapes took off, and we would call them mesh, and that's been a bit of confusion with women because they thought tapes was something that you might use in dressmaking, which is actually something that is made of linen or whatever. And the word tapes, I think, has caused some confusion, so we call them mesh tapes. So in 1998, there were just 214 women in England who had TVT and TOT. By 2009, the annual numbers of operations using polypropylene mesh were at an all-time high of 11,365 in England. That was a huge take-up. I mean, and can you just say to us, were you convinced at that time that this was the right thing to be doing? What was the role of the pharmaceutical industry in terms of ensuring that surgeons were aware of this operation and that their products could be used? And since then, we have seen a reduction, but not huge, but we have seen a reduction. And what impact did that have on colpo suspensions, which you've been talking about? Because we've seen the numbers decrease hugely on that, and I can understand why, because mesh was understood to be a much simpler, a cheaper operation in terms of bed days and all the rest of it. So just in thinking about what you do, are you now still teaching students how to do those colpo suspensions, or are you just saying no, mesh is the answer?
No, I'd never stopped doing colpo suspensions.
No, I do understand that. I've got your figures.
Okay, I had always, well, first of all, I didn't introduce tapes into clinical practice until we completed the first cohort of patients in the Warden-Hilton trial, because I'm a slow adopter on any new techniques. So it wasn't until we'd already produced the results from that, which were initially 6-month results, and then I was fairly convinced that it was a reasonable process to go through. And I train people in both TVTs, which I learned from Ulf Ormston in Sweden, and I train both those and colpo suspensions. But one of the reasons for continuing to do colpo suspensions is that I believe that if you have a procedure that fails, and a proportion of TVTs will fail, then it's a little bit illogical to do another one of the same procedure on the same woman, because there may be underlying factors that mitigate it being successful under any circumstances. So for redo surgery, I always did colpo suspensions, and that's why I've continued to train them. And I'm now training my 9th subspecialty trainee, and all of them have been competent at colpo suspensions by the time they've left me.
Were you surprised, though, when your colleagues, and many of them came forward and said they were very surprised about the ratings and how the ratings changed from a C rating to an A rating within a year?
I don't recollect that that's something that we discussed in great detail, but it may have been. And I think
is quoted as saying he was very surprised because there was no research to actually underline what was happening and why the change was made.
Well, of course, the TVT has been very heavily researched, and in fact, of surgical procedures, there are more publications in relation to it than most other surgical interventions. And they do show great efficacy with a relatively low complication rate. So I know that the HES data suggests 9% complications, but 50% of those are unclassified. So they may be something as simple as a urinary tract infection. And in our clinical practice, and obviously nowadays, because of the pause, we've all discussed this, we really don't see a huge number of women coming back. And the reason that there are so many women is because so many tapes have been put in over the last 20 years. With very little follow-up, because the NHS does not allow us to continue to follow up patients year on year. So we may see them once post-operatively, but then we might not see them again.
Would that be a good idea? Women have said if it come back every year, what
It
just
would
follows through?
It would be great, but who would resource it? It would be absolutely fantastic. And think of the long-term publications we'd have. But it would be the same as any other intervention, and no one is going to fund that in the long term.
Can I interject, Baroness, on your point about the huge rise in TVT surgery? I mean, the Colpo suspension operation, which I was trained to do in the 1990s, was a pretty brutal operation. It was done through an incision, sometimes quite difficult to see what you were doing if the patient was slightly obese. There were significant complications from that operation, in particular a rectocele, which is a prolapse on the back wall of the vagina, because it changes the vaginal anatomy. So when the TVT came along, I mean, I too was a late adopter. I think I put my first TVT in about 2001, but it seemed to be a very appealing operation for both surgeons and patients, in that the trial data was suggesting equivalence to Colpo suspension, but with a considerably quicker recovery. And I think the economic side was of secondary importance to the clinicians. I don't think we were really putting them in because it was cheaper for the NHS, but it was certainly a much easier operation for the patients, because I remember them sitting around for days afterwards, after Colpo suspension, with suprapubic catheters, being unable to empty their bladders properly. The TVT, you can adjust it if they are in retention afterwards. You can take them back to theatre and loosen it off. You can't do that with a Colpo suspension. So there were all sorts of theoretical advantages, and real advantages, and the mesh erosion issue, although it was always a theoretical risk, in practice didn't seem to be a huge problem. And that was borne out in our clinical experience. I mean, we published our own mesh erosion data. It was about 2 to 3%. And these aren't all major mesh complications that you've been hearing about from some of these women who have had terrible adverse events. But the majority of mesh complications were bits of fibre in the vagina, which could be trimmed down fairly easily, often without actually comprising the integrity of the sling. So they weren't all major complications that were difficult to deal with. So there was a huge uptake of TVT just because we felt it was a better operation for the patients. And I think because we felt it was such a good procedure, it was, as Professor Cardozo said, it was embraced very enthusiastically, I think, by both clinicians and patients, and hence there were people being treated who perhaps wouldn't have come forward for an old-style Colpo suspension because it was a bigger operation.
Did it almost by default become an alternative to conservative therapy?
I think that would be a fair comment. I mean, no. I mean, we always offered, well, should always have offered physiotherapy. I know there are some cases where that wasn't done, but it was never seen as a replacement to physiotherapy. But I think the threshold for surgery dropped.
I think one of the problems is that women's health physiotherapists are a fairly rare breed, and if women are on the waiting list to see the physiotherapist for a long period of time, and they know there's a small operation available that maybe their friend or someone they know has had, they will opt for the quick fix rather than wait a long period of time to see a women's health physiotherapist. And in our own experience, we've now got 300 women waiting to see one of our physiotherapists. One's on maternity leave, one's just left, and we can't provide those services for all women all of the time.
Can I ask you about the products now? Because we've obviously just had this news from the FDA that they have banned 2 of the products that have been produced. And in 2014, there were 29 different products had appeared on the market. By 2005 to 2013, there were 170,000 devices. Can I ask you about the devices and what your role you think might have been in by the pharmaceutical industry?
There were a lot of Me Too products. I mean, the one that was researched was the Johnson & Johnson the trial of compost suspension versus TBT, which is a type 1 polypropylene mesh. And then there were some other meshes that I didn't quite understand, which came on the market. I think there was one which was a different product, and there was no evidence for it, and should never have been introduced without evidence. But there were other companies, I think, producing other type 1 polypropylene meshes that were, copies of the Johnson & Johnson products. So, and there was definitely inducements. I mean, there were companies wanted you to use their products. We always stuck with the because that had the data. But I think it was reasonable to switch to another, perhaps if it was cheaper for the NHS, another type 1 polypropylene product that should have been equivalent, I think.
When you say
yes.
Could you be a bit more specific about the inducements?
I guess meals out, taken to conferences, that sort of thing. The normal.
But it is interesting because I have always chosen to use pubic TBT on the basis that they published the data, and I am very evidence convinced and evidence based. But in about 2005, our trust unilaterally took the decision to provide us with the product because it was sold to them for half the price. And one of my colleagues went into our day surgery unit, and all of the TBTs had been removed and replaced with a different product. And at that stage we said, no, we're not prepared to do this because we don't have published evidence that they are the same. They are a Me Too product. So I think that there are people around the country who are taken in by cheaper, seductively marketed products. But I think that you'd have to speak to those people to find out what it was that made them switch.
It's not just a message.
So was there any post-marketing surveillance done?
Was adequate post-marketing surveillance done? Not on all of the products, I don't think so. I mean, I didn't use them, but I don't believe they did. And the FDA initially was at fault because they were registering products on the basis that they were similar to another one.
Can I just say that's not just a mesh issue. I mean, we've had in our trust, sutures. I mean, sutures some of the sutures are implants, aren't they? They don't dissolve. We've had our sutures changed from ones that we've been using for many years and familiar with to other cheap products. So this isn't just a mesh issue at all.
And trocars for laparoscopy, you go in and they've got new ones.
So that's a supply procurement issue for the trust, and the clinicians you'd be saying have no role, although you've just said you refused to use the ones that they did bring in. That was effective.
I was effective in 2005. I wouldn't be as effective now. We are completely differently managed within the NHS. I don't even choose what goes onto my operating lists anymore. They're chosen for me.
And is there clinical input into the decision?
There's clinical input into the decision that a patient will undergo a certain procedure. There's no clinician input into which day that operation will be done.
Or what
the case mix, or what the case mix will be on an individual operating list, or necessarily what product will be used.
Does that compromise safety?
For what I do, in general, no. But there are people who are using far more devices and products, and it may represent a safety issue.
But there must be patients that you see, because of your experience and expertise, where you're the right person to do the operation in King's. And you're saying that you can't actually guarantee that you will do that operation?
Under most circumstances, I am able to stipulate, but if that patient is breaching the waiting times, then one of my colleagues, who is trained in urogynecology, will be asked instead. And I think, that's how it is in most trusts now. You cannot guarantee an individual. It even says on the consent form that no one specific individual will do your surgery.
I mean, there are some operations that are undertaken only by
There are. I mean,
virtual.
it's one of the things that makes a nonsense of saying that you need to do 20 of a procedure a year to maintain your competence at it. There are some things that I only do once every 5 years because they only occur that frequently, and playing the numbers game is dangerous. But it is much more difficult now than it was even a decade ago to provide the care for patients on an individual basis because we are very thoroughly managed within the NHS. I'll give you an example. We used to book our own patients, and we had a gynecology admissions officer. Our patients are now booked by someone who works in the dental school. They are pre-assessed by an orthopaedic nurse. So when they say, how long will I bleed for after my vaginal hysterectomy, they're told you should be able to walk on your knee in 6 weeks' time. And they are completely segmented into the places that they go to and are seen. And the lists are booked by administrative staff who decide based purely on how long a patient's been waiting for, unless they're a 2-week wait cancer patient, so that we don't have the same degree of input as we used to.
Is that true of Oxford too?
It is. It's not quite as bad as that sounds, but we would try and keep all urogynecology. Well, we would keep all urogynecology within the urogynecology team, and we work very well as a team. No, I think urogynecology would be patients would get an entirely appropriate surgery.
And Natalia, you'd agree with that?
Yeah, you have to work as a team. You can't rely on individuals in the team. You know, you get run out by the bus tomorrow. So, it's a team approach. But, so we do. So all urogynecology procedures are done by urogynecologists that are trained to do so in Oxford.
I mean, one of the things that was happening some years ago, trusts were managing waiting lists by taking a block of patients and passing it across to a private provider, and that private provider may be very good, but it may not have been. And that block would have included things like TVTs, which were seen as Professor Cardozo said, as seductively easy, but actually, can go very wrong in the wrong hands. But any operation can go very wrong in the wrong hands. So, I mean, it's difficult for the people running the trust, isn't it? They've got to manage their waiting list somehow. You can't have patients being able to choose their surgeon every time, I guess, if some surgeons are more popular than others, because waiting lists have to be managed, and it's difficult.
But you can if you go privately.
Yes, you can. I mean, the difference between private care and NHS care is you choose your surgeon and you don't not
and your timing of your operation.
Not kept waiting.
Can I assume that no one under the pause who should be receiving the TVT is being passed on?
No, I mean, I can speak for Oxford. The medical director of the private hospital will take his lead or her lead from the NHS, so the same clinical governance would apply.
That's what we would expect.
I don't know whether that's the same across the country, but certainly within the Nuffield group, which is the group we do our private work through, that will be the case.
We all four of us have decided right at the beginning that we would observe the pause for as long as we had to, and we explained that to our nurses, physiotherapists, patients alike. And to my knowledge, none of us have put in any tapes in the NHS or the private sector.
Can I just return to the subject of removal? So a lot of women have talked to us about being offered full removal or full vaginal removal, but it's subsequently become apparent to them that not all the mesh has been removed in their removal surgery. Can you help us understand what you would define as full removal?
Okay, before we talk about that, we need to just understand the different tapes, because there are transobturated, I mean, you'll know all this, but there's transobturated tapes, there's retropubic tapes.
Yeah.
Now, the problem with the transobturated tapes is that part of the mesh is in the groin, which isn't an area that gynecologists have ever been trained to operate in. So taking mesh out of the groin, and this is one of the things we were looking at on the anatomy course when I was talking at the beginning about declaration of interest. A dissection of the groin is frightening. There are all sorts of adductor tendons and nerves, the obturator nerve. So there are very few, if any, gynecologists that will be confident to go and dissect out a groin. So if a transobturator tape is to be taken out completely, by and large that would need to be done in conjunction with a plastic surgeon who perhaps has been trained to operate on the groin. That is different to a retropubic tape, where we are fully familiar with all of the anatomy in the pelvis and can take out a retropubic tape completely if it is appropriate to do so.
But it isn't always appropriate to remove the whole of the tape. If a small portion of tape under the urethra is exposed, it's perfectly reasonable to remove that small portion of tape. And if it has been in situ for more than about 6 months, it's quite likely that continence will be retained, which was the purpose of putting the tape in the first place. So I think, once again, it's about expectations, but leading women to believe that having the whole tape removed is going to solve their problems is often inappropriate.
To most of the women that we've met that has been the issue, it's been about pain. Pain in the groin, pain down the legs, pain
I would agree though that removing a retropubic tape is not that difficult and not necessarily necessary. Removing an obturator tape is much more of a problem.
I think the morbidity profile with the transobturator tapes is very different to the morbidity profile with the retropubic tapes. And I was very pleased to see actually in the NICE guideline that's just been published that actually transobturator tapes are effectively not going to be put in anymore.
And then the only reason...
there was never...
the only reason, in my opinion, for putting in a transobturator tape, and I've used them a handful of, well, maybe 2 handfuls, but not that many times over the years. But for women who have a real problem retropubically, if they've got a plated pelvis from a previous pelvic fracture, or there is some reason why you cannot, or it would be dangerous to enter the retropubic space, for those women, when appropriately counseled regarding the complications, risks and benefits of the procedure, if they can't have a colpo suspension or a retropubic tape because it would be dangerous to go in the retropubic space, then for those very limited women I would offer it, but not for others.
Presumably in the specialist mesh removal centres that are being commissioned, they will need to be aware of the need for a surgeon able to dissect through the groin and familiar with the
Usually a
obturator
vascular
frame.
surgeon.
And we need some more research in the area because it's by no means clear that if you've got groin pain, taking out the mesh is going to cure the groin pain. Because if the pain is due to nerve damage, then an operation isn't going to rectify the nerve damage. Indeed, it may cause more nerve damage. So, we've still quite a long way to go before we really.
We've met women who've gone abroad to have it removed, and they've said to us that they've been told that it's important to make sure that you know how much went in terms of centimetres, so that you know how much you've taken out.
I'm not sure I agree with that. I mean, once you find the mesh, you follow it to its entirety. I mean, you don't...
But you can't follow it through the obturator foramen.
Well, you would be doing it from two...
Yes, quite. That's what...
You can't remove it entirely vaginally.
That's what my point is, that they said, so one of the reasons you follow it is you've got to then follow the whole thing. So, because otherwise, if you... I mean, I don't have to do these operations. I'm reporting what we've been told.
You can't measure how much you put in, but you can measure how much you lop off. So, yes,
but you can measure how much you put in, because you can record that when you put it in.
Well, we don't record it.
No, but you could.
Well, we need to know what type of transobturator tapes. Removing them, there are so many types that I never knew about until... So before you go for surgery, make the decision to remove, you need to know what transobturator tape was put in, because there are huge variation, and then, and make decision. But it's such a broad topic, such Antler, that, to start with mesh removal surgery, counseling patients, making decision is more difficult than surgery itself. And that's what I'm particularly for chronic pain. So when there is obvious problem with a mesh, such as erosion or sepsis around the mesh, kind of decision making is easier. When you get a patient with chronic pain, with no erosion and no findings on imaging that there is a problem, decision making is a lot more difficult to even do in surgery itself. And that's what particularly beneficial, what I can see in NICE guidelines, that decisions are, regional MDT going to make those decisions, because the outcome data for mesh removal for chronic pain, we still don't have robust outcome data. And we need to make sure that patients are not worse off after this surgery. So that's very important, because those patients will have further continence surgery after removal or further prolapse surgery, and it's a cascade of operations with this risk morbidity. So to start with, counseling before surgery. Going back to obturator tapes, you can't remove transobturator tape vaginally entirely. You need a groin dissection, either traditional transperineal or alternative would be laparoscopic, but also with laparoscopic technique, you in some cases can remove entire mesh, or you need a groin dissection in combination. And yes, it's multidisciplinary approach, and I would think plastic surgeons would be the best people to support us, and they do.
Have you had occasions where the mesh has gravitated at all? Have you had occasions where it's shrunk, where it's stretched, where it splinters? I mean, I just want to understand the product, because these are the sum of things that we have heard.
Yeah. I think mesh doesn't break in pieces and splint and travel somewhere. I think that's myth. I think that's what probably mesh erosion. Mesh can erode into surrounding structures such as vagina, urethra, or bladder or bowel, and I think that's what probably splinting of the mesh is perceived by yes, regarding shrinkage, there are conflicting data about shrinkage, and there are some evidence that it shrinks when it's in place, and at the same time we don't know to what degree. So, but mesh can definitely, yes, there is a risk of mesh eroding into surrounding structures with this type of surgery, and even sort of we see cases when that happens 10-15 years down the line.
And of course, women change shape over the years sometimes as well. So if you put a tape in a very slim woman and then she becomes grossly obese, it's quite likely that the tape will not perform in the same way as it would have. And similarly, when a woman becomes postmenopausal and her vaginal tissues and her urethra become more atrophic as a result of lack of estrogen, then similarly, the tape can cause problems, not because of the tape, but because of the aging process or the changes in a woman's body.
Mr. Walker, can I welcome you? I'm sure you got lost in this building.
No, my apologies. Having got caught up last week, this week I was asked to come at 2 o'clock, and there was a miscommunication as to the start time, so I was patiently waiting at 1:45 to 2, so my apologies.
Nevertheless, you're very welcome. Thank you very much for coming. And perhaps you could just say, for the benefit of the camera, who you are and where you're from and your specialty.
Thank you. Yes, my name is Roger Walker. I'm a consultant urologist at Epson and Helier, and the clinical lead for our regional MDT and specialist mesh team.
Thank you very much. We were just talking about the removal of mesh and the difficulties that occur, and we have been through several other conversations, but I won't bore you with recapping them all.
Baroness, can I just follow on from what Natalia was saying? So we haven't in Oxford seen any cases of mesh migrating to distant places in the body, and we haven't seen any cases of mesh spontaneously breaking up. So, we have had a number of women who have, I think, probably been misinformed by some of the media reports have not been entirely accurate. I mean, mesh is an extremely complex area. We've had some patients who've had a variety of symptoms that they've attributed to mesh, which we felt on balance have not been due to mesh. The erosion into the adjacent viscus is a very genuine problem, which we see Happily, not too often, but it's that would be the commonest complication we've seen with the mesh implants that.
I would have to concur. We haven't seen distant mesh migration in the same way that we know that Teflon migrated to distant areas in the body when it was used as an injectable. So I think it is completely different. And when we have, collectively I'm sure, been called upon to remove bits of mesh or tape, many years after it's been inserted, because it's eroded, it is configured in the same way that it was when it went in.
The other, I think, bit of misinformation is when the mesh is removed and it's sent for histology, it almost invariably shows a giant cell foreign body reaction, which some patients are understandably interpreting as a sort of toxic reaction to the mesh. It's not. That is a normal host response to an implant.
And how long would you expect that to continue for as long as the implant is in place?
One would have to ask that question to a histopathologist, I think, but I suspect indefinitely.
So do you think we have enough knowledge and data about the long-term effects of having mesh inside the pelvis?
Well, I don't think you can ever have enough knowledge, can you? I mean,
do we have enough in order
any
to carry on
operation
using the
is a learning process. I mean, medicine is a technology that moves on, and we're doing things now that we probably won't be doing in 20 years' time. I mean, that's just so one can only have a certain amount of follow-up, but we do have a lot of. I mean, we've got 20-year data now with mesh. I mean, Linda's been putting mesh in for more than 20 years. I've been putting mesh in for 20 years, and we're not seeing a huge number of people coming back with complications. That's not to diminish the complications. There are some very sad stories, and there are things that we have done wrong as a profession. But one needs to understand why mesh has been put in the first place, because the operations that we had before these mesh operations came along were not good operations. I mean, vaginal prolapse, you just end up repeating the surgery and taking more and more vaginal tissue out, and you completely lose vaginal function. I mean, it's not your remit to discuss the abdominal meshes, I know, but the abdominal meshes have very good safety profile. I think the transvaginal meshes for prolapse have not had a good safety profile, and I don't think those are going to be. They haven't been put in for some years in most centres now. I mean, mesh is very important for any reconstructive urogynecologist. If we haven't got access to mesh, there are problems that we cannot help patients with, because the tissue, the connective tissue, is weak. And you've got to do something to strengthen the tissue. The ideal would be to be able to grow body parts, but we can't do that yet. So,
but polypropylene mesh is used in hernia repair and has for a long time. And if we look just at the published data, 6% pain with polypropylene mesh for hernia, 4% mesh complication for TVT, retropubic traditional. They're not that much different. And if you look at the British Society of Urogynecology database, there are now 40,000 TVTs on it. And I appreciate that there will not be a lot of long-term follow-up, but there has not been a huge amount of complication reporting. And certainly from many, many years' experience, I have not seen a high complication rate with retropubic TVTs. Not in the same way that we did when mesh was being put in transvaginally for prolapse repair, where a much larger piece of mesh is employed.
Can I change the subject a bit? Because you will know of the 5 safety measures that we said must be introduced before any further surgery is taken for urinary incontinence, etc. Can I just ask you your views about a database and whether you think that the information we gather now is sufficient in order to ensure that we can see the trends that are happening, and that it could certainly help in the future to see exactly what is happening with this particular operation. So the perhaps I could ask you, because
Yes,
to bring you into the
Opportunity.
conversation. Any views on a database?
I mean, I think without doubt, a database should be mandatory for incontinence and prolapse surgery. To what extent you take that database in terms of what information you collect at the outset and for the length of time you maintain follow-up data are the nub and crux of it, really. But there's no doubt that to have a database in the first place would be a very important step in the right direction.
What are the sort of things you would want to see on a database?
Obvious demographic data about date, time of surgery, what surgery was performed, what mesh or sutures were used, some early follow-up data, and a recording of complications as they arose down the line. What I'm sure has been touched on as part of this review is what complications are attributed specifically to mesh or product complications and what complications are related to the general complication you'll see as a result of an operation. For that indication is difficult to disentangle, but certainly having a complication recorded is important.
I think it's very important to have some quality of life outcome data, because quality of life is what the patient measures. It isn't purely a matter of success or complications, it's how our quality of life for a non-life-threatening condition has been changed. And I think the British Society of Urogynecology database does a good job. I think what's bad is the people who are doing the surgery don't always input their data, and the trusts don't always allow follow-up of patients, so you don't get the outcome data.
When you say they don't allow follow-up, could you elaborate a little on that?
Do we allow follow-up?
When you said the trusts don't allow?
There are a number of trusts throughout the country who will not have a physical visit for a patient to the outpatients clinic after a procedure, but will have virtual clinics where the patients can ring in or the nurse can ring out, and the patients will be followed up verbally, and if they say they've got no complications, they may not be seen post-operatively.
I mean, there's a lot of pressure from the NHS to move follow-up back into the community, back with the GP or with the patient themselves. So to create a database or a follow-up process that involves patients being more closely monitored is at odds with some of the pressures within the health service.
Have you any views on the MHRA, the regulator?
Do I have views on it? I think we've been very inefficient in reporting to the MHRA, and I've just been to do a visit to a gynecology department in difficulty in the UK and noticed their appalling reporting of complications to the MHRA, so I suspect it's a widespread problem. On the British Society of Urogynecology database, there is now immediate access to report complications to the MHRA, which is a great advance, I think.
I mean, that's been one of the positives of the high vigilance mesh restriction, because the medical directors are now ensuring that anyone putting mesh in their trust is reporting to MHRA, and that will be part of their annual appraisal and revalidation and everything else. So I think, one has to have a robust method for reporting complications. The problem will be, of course, if we're not following patients up at, I'd have thought probably 1 year and 5 years would be a sort of a reasonable minimum. You're not necessarily going to know about all your complications. I mean, one can argue if the patient's asymptomatic, then perhaps you don't need to know about the complication, but I'm not sure that's the case. So ideally, you'd be reviewing and examining your patients at 1 year and 5 years and reporting any mesh complications to the MHRA.
Do you think that you see patients with complications? Do you think they are referred back to you, or do you think they're possibly referred to other services?
It could be either. I mean, if you're working in the tertiary unit, you're probably the only unit around who's dealing with the mesh complications, so we would expect to see most of our complications back, plus complications from other units around. But
that will be different in Oxford from London.
Yes.
Because in London, the GPs will refer to the department with the shortest waiting time in the patient's interests, rather than necessarily referring them back to the place where they had the index surgery.
But there is geographical mobility, so we won't certainly be seeing all our complications back. And
to come back to the MHRA, I think the thing that has changed and improved is actually the ease with which you can report complications. It used to be quite a lengthy process.
Yeah.
I think in recent years it has become a lot more straightforward.
A clinician last week said to us, reporting to the MHRA is like reporting to a black hole. Black holes being quite topical these days. I'm not quite sure what they were expecting back from the MHRA, but what would you want to see back from the MHRA?
It would be nice to see some sort of annual output of data complications. I mean, they do report back what you've reported to them, so you do get a response in the sense that you feel you've reported. And it should form part of your individual surgeons, your unit's appraisal data, your assessment process. So it's valuable in that respect. I'm not sure outside of big reports, reviews, that the MHRA is really any obligation or anything I would expect to get back from them, to be perfectly honest.
it's more of a national trigger, I would have thought. I mean, on an individual basis, you're perhaps not going to pick up on things very quickly, but if you're getting data from the whole of the country, if there's a faulty product.
But that does rely on people reporting to them.
Well, but that is now mandatory.
It also depends on recognising complications as complications. So, I think you just mentioned, if there's a case for saying, well, if the patient is asymptomatic, then job done, there is no need to.
We can cite an example for that. If a patient is not sexually active, she could very easily have a small erosion of mesh into the vagina, and no one would know about it because it wouldn't cause any problems to her. Now, should that be reported? I don't know. If she's not coming forward, you don't know that it's there.
I mean, we telephone follow up some of our patients. It's a terrible problem for some of them getting into the hospital. The parking's dreadful. It's very convenient for them to have a telephone consultation with one of our urogynecology specialist nurses. They're clearly not getting an examination as part of that. If they're reporting symptoms, they'd be brought back for review and clinical examination. But if they're symptom-free and they're happy, they wouldn't be examined.
With great reluctance, I'm afraid I'm going to have to bring this to a close because we've got another meeting we've got to go to. And I'm so sorry. I don't feel that Mr. Walker, you've really had a chance to come in. But any further thoughts you have, you are very welcome, and perhaps you could send by email or whatever. We welcome that. And I'm sorry about the timing. I know it was changed, and I'm sorry about that. So I'm just going to ask my colleagues, first of all, have you got any other questions?
Just a very quick one. It has been mentioned to us that where there has been mesh removal, one of the complications is hernia repair needing to be done. How common is that? And for a woman who's had mesh taken out, who doesn't want to have mesh hernia repair, does she have much option?
Well, that comes to the question of decision making. How far you go if you do mesh removal, and it leads to, as a patient needs to be counseled. This is where I'm coming back to this.
I don't know how common it is.
Yeah. Well, there will be like with any surgery, there will be a risk of incisional hernia following any surgery, laparoscopic, open, abdominal. There's a point we have to make. So decision making about mesh removal, particularly when it needs to be weighed very carefully against benefits, risks. We know the outcome of this type of surgery can be unpredictable. We cannot guarantee complete resolution of the pain, and we need to balance this against the risks such as incisional hernia.
So does that happen reasonably commonly? I have no idea of the scale of that.
I haven't commonly seen a huge recurrence in.
I I think it's fairly
prolapse or
rare.
hernia after
Yeah.
mesh removal, and there are non-mesh related options for surgical repair.
Correct. Yeah, it's relatively rare, but it's still mobility. And one case in 100 is bad enough. It's individual. So, yeah, the risk benefits need to be weighed very carefully.
The main problem is recurrent stress incontinence and how you then manage that.
Really an observation. I think it's terribly important to make sure as a doctor that you actually have a lot of influence over the doctoring. And one advantage of having a proper database connected to a register is that it could empower the doctor-patient relationship so that you can actually then find imaginative ways of following up your patients, and they have imaginative ways of contacting you when things go wrong. Do you think that's a reasonable observation?
I think a lot of our doctoring skills and abilities have been taken away from us, and I think it's much harder to do that now than if you'd asked me 20 years ago.
Yeah, I agree with you, because some of the scenarios you describe would not have happened to me.
So I think,
but, I understand where the tensions arise, but one advantage of having a properly constructed register, and we did have that for kidney transplants in children, but the numbers were much, much smaller, is it does give you the capacity to maintain a relationship both ways.
We can all take our own data off the British Society of Urogynecology database, either for our trust or for us as individuals, and we can all report those data to our patients over the last 10 years. So, I mean, I think it's going in the right direction.
Yes. A database that patients could access to would be great, wouldn't it? Because you'd have a much richer database.
That's it.
And
that's it.
You know, sort of TripAdvisor for it's that would be fantastic, wouldn't it? But it would require significant IT support from
and funding.
Get that.
So there are other societies that have British Society of endometriosis surgery that I also belong to. They have a database with open access, so patient can enter a database. The only thing they have to have, patients have to have access and IT skills and emails, and some of our elderly patients who do suffer with pelvic may not.
But even we elderly patients are getting there.
Elderly patients have more time to access it.
You don't understand elderly.
Thank you.
Sonia, any questions?
Just a question. Once the conditions of the pores are lifted, what level of mesh surgery do you sort of expect to see?
Well, women are frightened now, aren't they? They've read the media, they've looked at the press, they see social media, and they think, do I really want to have that surgery carried out on me? And to an extent that's a good thing, because as I said at the beginning, people became very enchanted by a seductively easy procedure, both for the patient, the clinician and the NHS. So I think being circumspect in the future is a good thing, but there will be a proportion of women certainly who will be very much relieved to see the reintroduction of retropubic TVTs. And I don't know how many of us you've spoken to, clinicians in female urology or urogynecology, but I think that most of us would welcome being able to offer retropubic TVTs as one of a range of options for women with urinary incontinence who require a surgical solution.
I mean, I think certainly in my practice in our unit, there are a number of ladies who are still coming through the door saying, my mum, my aunt, my sister had this procedure, can I have it? I've heard the adverse media reports, but they're delighted and had a wonderful life. You give them the option to say, I'll wait until this review has ended and it reinstated. So there are patients out there who are at the other end of the spectrum from the unhappy patients who...
And to put it in perspective, any prosthetic device has a complication rate. Look at what happened with hips when they were introduced and how awful and terrible press they got. And now we take it for granted that people will have a prosthetic hip, prosthetic heart valves, that they're all widely used and they all have a significant complication rate.
I had one.
Which, the valve or the hip?
The valve.
All right. Any questions from us? I'm sure.
No, I'm very grateful to you for seeing us, and I hope that we've given you views that will be helpful in drawing your conclusions. And I think we would all very much welcome the pause coming to an end, or at least knowing when it's going to come to an end, so that we can give patients realistic expectations.
Especially when the 5 conditions to increase safety are met, because we all share the view that we want as safe NHS as we can possibly get. Right.
Just a quick, is it within your remit to also talk to women who've had good outcomes from mesh? Is that part of the picture you're getting?
We haven't certainly set out any sort of communication to attract them, but in the course of one's ordinary life, I've certainly heard a number at conferences and things like that.
Because I mean, clearly you know this, but it will be skewing your view significantly, I think, if you are only speaking to the women who've had a poor outcome.
Well, we certainly believe in the cautionary principle. At first, do no harm. Thank you very much indeed. Thank you for coming.